Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly television program about the events, people, and happenings here at Southampton and in the healthcare scene on the South Fork of Long Island. So welcome. And today we have a very new member of our medical staff, Dr. Heidi Roppelt. Dr. Roelt is a rheumatologist. We'll talk a little bit about that. As always, we try to understand the various medical specialties and their interests. But first, I'd like to welcome Dr. Roelt. And as I always do, could you tell us a little bit about yourself and your background and training and how you ended up here in Southampton Hospital? How did you find us here at Southampton?
Absolutely. Well, first of all, thank you, Bob, for inviting me.
Thank you.
It's a privilege to be able to participate. I grew up overseas. That's my background. I consider it important mainly because I'm fluent in Spanish, and that has been one of the single most helpful skills with our patient population. I did
large and growing Spanish-speaking population
absolutely.
Here, certainly. Right.
I did my medical training at Tiedemann in Philadelphia,
right.
and then residency at Stony Brook University and fellowship there.
Okay.
Stayed on as faculty at Stony Brook, so I've been there altogether for about 15 years and was head of the rheumatology division as well as program director for a number of years. And we have lived out in this area for that entire time, so my choice to come to Southampton has sort of been selfish in the sense that I wanted to be closer to home,
right.
And it's been a great experience thus far.
Well, I'm glad we finally got you on board here at Southampton. Certainly an asset to us in the community.
Thank you.
Let's talk first. I know we're going to talk about osteoporosis today, but first let's talk a little bit about rheumatology. And sometimes people don't know all of the various specialties. What is rheumatology, and what's the training for a rheumatologist?
So rheumatology is a diverse subspecialty. It covers autoimmune disease, which includes everything from the arthritides like lupus, rheumatoid arthritis, osteoarthritis, to more obscure conditions like Behçet's disease, and we also cover osteoporosis, which wouldn't initially be thought of as an autoimmune condition. So it's a fairly diverse field.
Yeah, and I know when I was looking at the preparing for today and looking at some of the questions, I thought osteoporosis, that's kind of interesting for rheumatology. What is the training for a rheumatologist also?
After residency for internal medicine, the subspecialty is a 2-year fellowship.
Okay.
Sometimes 3 years if you do a separate 1-year research year as part of your fellowship. And mainly it's 2 years of fellowship.
Great. And I know it's a separate board certification
Absolutely.
as well, right?
Yeah.
Great.
Mm-hmm.
Okay, so today we're going to talk about osteoporosis, something we hear about. Certainly see a lot of it in the advertisements for on TV. I'm interested, well, first of all, what is osteoporosis? Let's talk about that.
Osteoporosis is characterized by a disease where there is a loss of bone mass or bone density that causes a weakness in bone, leading to potential bone breakage or fractures. So it's basically a condition that commonly occurs in women after menopause or in older persons as they age, where you have weakening of the bones that shouldn't be there. Okay. This is physiologic. It's common after menopause for women to lose bone. In fact, it's absolutely natural to lose bone because of being in a low estrogen state. But it's basically a disease of low bone mass and bone weakness.
And how do rheumatologists get involved with osteoporosis? That was interesting to you.
I'm not sure of the history of where rheumatology came in, probably because it deals with bones to begin with, and you know, as a field that primarily emphasizes arthritis and the arthritides and bone health. Okay. We are involved, but it's a shared field amongst the endocrinologists, OB-GYN, and rheumatologists. So it's certainly a field, you know, an area with regards to osteoporosis that we share with other subspecialties.
And how do we diagnose osteoporosis? How do we know we have it? So.
You don't know you have it
Okay.
unless you're screened for it.
All
The
right.
screening test is a bone density, also known as a DEXA, which is short for dual energy X-ray absorptiometry.
Okay.
A screening test should be done on most women after menopause and on most men after 50 if they have some risk factors. But I would say overall, anyone, any postmenopausal female who has reached the age of 65 and hasn't had a bone density should get one.
Okay.
And any male over the age of 70, if they've never had a bone density, they should have one. Otherwise, it's a silent disease. We don't know that it's present until we break a bone, and by then it's too late.
Okay. And what are those risk factors? Why would somebody earlier in life look at get a man under 70, for example? What are some of the risk factors?
So risk factors for osteoporosis include being postmenopausal in females.
Okay.
So just being in a low estrogen state puts you at risk. Age in and of itself, the older you are, the greater the risk for osteoporosis. A family history of osteoporosis, specifically a hip fracture in a parent. So if you know that mom or dad had a hip fracture, your likelihood of having osteoporosis is much higher.
Okay.
Smoking and significant alcohol use are both risk factors. Having a inflammatory systemic disorder like rheumatoid arthritis is a risk factor.
Okay.
And caffeine use. So if we drink 5 or 6
Caffeine,
coffees,
no, I love my coffee.
5 or 6 cups of coffee a day, you might want to cut it back to 1.
Okay, all right, interesting. So let's talk a little bit about bones and go right back to some of the basics on it. What is the, tell me a little bit about the structure of bones, how they grow, and sort of what's going on when a bone becomes osteoporotic, I guess. So.
Our bones are divided into 2 main types, cortical bone and trabecular bone.
Okay.
Cortical bone is what we think of when we talk about long bone, so your thigh, arm bone, that would be considered cortical bone.
Right.
Trabecular bone is a lattice or woven bone that is prevalent in the spine, part of the hip, distal wrist area.
Okay.
And what gives bone its strength, in cortical bone, it's sort of the side edges. So when you see that long bone image on an x-ray, for example, if you've ever looked at that, the sides of the long bone are thick and strong, but inside there's a lattice work of triangles. And that lattice work provides the scaffolding for the bone overlying and scaffolding, obviously, overall for the body.
Okay.
In osteoporosis, because we're losing...
Almost looks like a honeycomb sometimes when I've seen
well,
it. Right.
that's when it's abnormal.
Oh,
so
all right.
in osteoporosis, when we start to lose bone, the area that's most affected, or the area that's affected first, is that woven or trabecular bone.
Okay.
And those areas that are woven become thin and are at risk for breaking. So when they break, then of course holes are formed, and it isn't hard to imagine that you can then get a break of the total bone because of the weakness underlying. With regards to building our bone, we build bone in adolescence. So usually this talk or this type of discussion should take place in high schools.
Okay.
That is the time where you have the greatest bone growth and where you're going to reach your peak bone mass over the course of your lifetime. So by early 20s, you should have reached your peak bone mass, whatever that's going to be.
Okay.
After that, normal physiologic bone health is that you get a slow decline in bone. It's perfectly normal.
Right.
And in women, once you hit menopause, the decline becomes more rapid, but again, there's a slow decline in bone.
Okay.
What happens in osteoporosis is an imbalance in the cells that come in and form bone versus the cells or that come in and take away bone versus the cells that form bone. For example, you and I sitting here have micro cracks. So even though our peak bone growth is when we're younger, we still remodel over the course of our life. We still make repairs on our bones over life.
Okay.
Sitting here, you have little cracks in your bones, and there are cells that come in, take that crack away.
Cracks from injury, just naturally occurring,
just normal movement, exercise, walking, sitting.
Okay.
So cells come in and take that crack away, or take away that little piece that's slightly off, and cells come in and fill it back up.
Okay.
In osteoporosis, for a number of reasons, there's an imbalance in the cells that take away bone versus those that replace it.
Right.
So that you have more taking away a bone than filling it in.
I see.
So we really need to even that scale to treat the disease.
Okay. And it's the lattice work, you said, that seems to be attacked first as...
It's just because those spicules in the lattice are thinnest, they're more susceptible to being affected by this.
So how prevalent is osteoporosis in America? If everybody, is literally everybody basically going through this process as they age? So.
Everyone does get bone loss over time.
Right. Okay.
But depending on where you start and a whole bunch of factors in between, you may not become osteoporotic in the end.
Okay.
The prevalence of osteoporosis in America is about 45 million Americans have osteoporosis.
Okay.
Or, I'm sorry, 45 million Americans have either osteoporosis or are at risk for the disease.
All right.
Of those, 10 million actually have osteoporosis,
Okay.
and 35 million are at risk for developing it.
Wow.
So it's extremely common.
Okay.
A little more common in women than in men. In fact, 1 in every 5 men over the age of 50 may develop an osteoporosis-related fracture or broken bone. And in women, it's 1 in 2. So
1 in 2,
50% of women that are postmenopausal will have an osteoporosis-related fracture over the course of their lifetime.
So what's happening in women that's so much more prevalent? Why a difference for women? So,
I think it's a combination of factors.
yeah.
Being in a postmenopausal state, so you don't have that protective estrogen component.
Okay.
Also, in general, women are smaller framed,
Right.
so they start with a lower
They
bone
start with smaller
mass.
bones. I was going to ask that.
Absolutely.
It's smaller to begin with. Okay, interesting. But it does sound like it's clearly an issue with men also. I've seen discussion about women, the need. All the commercials seem to be women in it, but it's clearly something that's happening in men as well.
I completely agree, and that's a population that we are trying to educate the public about. Men are not being screened as avidly as they should be, and we're missing osteoporosis in men because it's not being thought of. So it's very important that we consider screening in men.
I try to avoid some of the risk factors. I don't smoke, I don't drink, I eat a healthy diet. I'm assuming a healthy diet is a good thing for bones. Can I still be at risk for osteoporosis?
Absolutely. So, when you say healthy diet, we mainly are thinking about things that are high in calcium and vitamin D. Those are the building blocks for bone. So a diet deficient in those things, it just adds to the problem. But you could have done all of the right things, exercised in adolescence, eaten an excellent or high calcium and vitamin D diet during adolescence, reached your peak bone mass, as you should have, and still be at risk for osteoporosis. There are a number of other factors like genes. So your genetic build, if your parents had osteoporosis, the likelihood that you may is greater. And then, medication use. For example, if you take certain medicines that put you at risk for loss of bone, you may still develop the disease.
The risk factors, if I were going to change some things in my life, what would be the major risk factors you would recommend that anyone really focus on? And are there risk factors that we can change? Clearly our family history usually isn't something we can change, even if we'd like to, but we can't. But are there other risk factors that we can change?
So I would say the most important thing to look at, first of all, is screening.
Okay.
Make sure that if you're in the right category to be screened, and that should be a discussion with your doctor, that you get the test, because you're not going to know whether you have a low bone density or whether your bone density is perfectly normal.
Right.
Once you do get a bone density done, if it shows any abnormality, the things that you can change would include exercise. So weight-bearing exercise, no matter what your age is very important. Usually 30 minutes a day. 3 to 4 times a week is adequate. And when I say weight bearing, you don't have to start jogging. You can, go for a walk around the block for 30 minutes, or from there, anything to weight bearing, weight training is helpful. But certainly, at least, walking or a slow jog is very beneficial. Diet is important, so everyone should be taking calcium and vitamin D,
Okay.
and if they're not, there should be a reason for it, meaning that they've had either side effects from the medication or kidney stones or some other problem why that would preclude them from being on those vitamins. But you absolutely should be taking calcium and vitamin D supplements.
You would say that the supplements, not just in the food alone, is good enough, or I guess you'd have to be very careful about what you're eating to make sure you're getting enough. So.
For most people, it requires supplementation.
Okay. And exercise, I'm interested in that. Why weight-bearing exercise? What exactly is happening in exercise that's strengthening the bone?
So we talked about those micro cracks. When we exercise, we put stress on the bone.
Okay.
And by stressing the bone, it causes an increase in bone growth, or an increase at least in repair of those microfractures. Now,
Almost the way muscle grows with exercise.
Absolutely.
Okay.
And in fact, it's the only condition, osteoporosis is the only condition
Right.
Where obesity is helpful.
Really?
Having, carrying around increased weight is actually a negative risk factor for osteoporosis.
Okay, because it's putting you're
putting stress
doing,
on the
I guess
bones.
you're doing weight training almost with the. It almost sounds a little counterintuitive. You've got a risk of bone fracture, but yet you're doing exercise to strengthen the bone, which is actually causing little fractures in it. It sounds a little counterintuitive to me, but people shouldn't be afraid to exercise.
Absolutely not. And the other benefit of exercise is to do gait training and balance type exercise. So Tai
Okay.
Chi is very helpful. If you don't fall,
Right.
you're not going to break a hip.
Okay.
So people at risk for falling have a higher risk for breaking, say, a hip. And that's
I see.
really the fracture that we worry about. So exercise is beneficial in many other ways.
I was going to ask you that question. Where are the primary sites for osteoporotic fracture?
Most common site is the spine, usually
Okay.
the middle of the back. So people that complain of low back pain, that's probably not related to an osteoporosis fracture. It's usually in the middle of the back.
Okay.
Other sites include the wrist
Okay.
and the hip, which is where we, that is the fracture that we worry about the most.
All right.
People that have hip fractures, just to throw out a statistic, 25% of people with hip fractures will require long-term care, and death absolutely can occur related to the mortality of the fracture itself. It's not because of breaking the bone, it's because of the comorbidities about being bedridden,
Okay.
the surgery associated with repairing the fracture, like getting a hip replacement, and the rest. So the mortality in hip fractures is high.
Is a replacement in the hip, if you suspect that there's an osteoporotic hip, an option?
Yeah, so if you have a hip fracture related to osteoporosis, unless you're not a candidate for surgery because of other medical conditions, the treatment would be to replace the hip.
Okay. You've described it as a silent disease. Are there any early warning signs that if I weren't screened or anyone could look for that might be an issue? Other than family history, possibly?
No, there really
Okay.
aren't. I wish there were.
Yeah.
Unfortunately, there's no way to know who is going to develop a problem without screening, without knowing whether your bone density is already low and you might be at risk.
Okay, so let's talk about that screening. The test you described as a DEXA screen. What is it? What does it involve? Does it? People often are afraid to get tests because they think something's going to be poked in them or whatever. What is the procedure? Can you describe what happens?
A bone density test is a radiologic study. It's an imaging study. Patient lays on a table. There's a single arm that comes over the table, images the hip area, the low back, and sometimes, if needed, the wrist.
Okay.
It is not claustrophobic. It's a single arm. It's not a tunnel that you have to go into.
Right.
The amount of radiation that you get in that test is very safe. In fact, flying from New York to California would expose you to more radiation than a bone density test.
Really? Okay. So it's certainly something that shouldn't be avoided for any, there's no invasive procedure or anything for anyone to really be afraid of with the test. So.
Absolutely not.
And once I've been diagnosed, I'm saying anyone is diagnosed potentially with osteoporosis, is there, what happens next? What do we do? How do we treat it?
So the most important first step is to make sure that you don't have osteoporosis or low bone density from some other medical cause. That it's just, I shouldn't use the word just, but that it's from being either postmenopausal in a woman or in a male just from aging. So number one, a number of tests are usually done to exclude hormone problems.
Okay.
Having a low vitamin D. Now we don't expose ourselves to the sun as much because of concerns for skin cancer, and that's the primary source for making vitamin D in our bodies.
More reason to take those supplements, I guess, right?
Absolutely. So many people are vitamin D deficient.
Okay.
So a low vitamin D puts you at risk for a low bone mass or osteoporosis.
Right.
So once we exclude all of those other medical conditions and we're left with, yes, this is osteoporosis, primary osteoporosis, there are treatment options. There are a number of medications that are very effective at preventing further bone loss, and this is a key point. We can't build more bone with most of the medicines that we use. We can't put bone back. Okay. The goal is to prevent any further loss, which is why diagnosing this condition is so important early on. Once you actually have fractures, once you actually have osteoporosis where things are breaking, it's very difficult to put back bone. There is only one medicine on the market that does that.
I didn't realize that. I thought all the advertisements, I thought it was actually helping you rebuild bone, all of these other drugs. No.
Not really.
So it's really just stopping. Is there a cure? Is there an actual cure for it?
There's no true cure. I mean, when we think of, it would be like asking if there's a cure to aging.
Okay.
No, there's no real cure. We have medications that can prevent further bone loss, but we don't really have anything that cures the disease.
Okay. So once I know I've had it and I'm trying to prevent any further bone loss, what are some additional steps that someone should take?
Really, it's back to the basics. It's the exercise regimen. You can never exercise too much. It's always a good idea to make sure that you're doing some kind of exercise, and always beneficial for the rest of your health issues.
Right.
Making sure that you're taking calcium and vitamin D. So I think just providing the building blocks for bone and exercise, balance, and so forth is key.
Somebody who hasn't ever exercised, and a lot of Americans unfortunately are somewhat sedentary, what would you recommend?
Really, just to walk around the block for half an hour, which would probably cover a number of cycles.
Right, exactly.
But it doesn't
Unless
have
you
to be
a big
jogging
block,
or strenuous.
Yeah, exactly.
And I think the biggest hurdle to exercise is the routine, getting into a routine that promotes being active.
Okay.
So it's not as important what you do in that half hour so much as doing that half hour. And then you'll find that over time, if you really set aside the half hour, you do more within that period. So I've had patients that never exercised that come back, a year later and say, I'm really jogging 4 miles now, which is amazing to me. So you can work up to doing more rigorous exercise.
Any truth to the fact that the exercise also strengthens muscles and things as well, which may help prevent?
Sure.
Right.
Yeah, because it helps with balance and it overall helps providing strength around your bones, so it's beneficial.
So that balance sounds very important as well. The issue of potentially just falling, landing on a wrist, landing on a hip is a real challenge for us. Any recommendations for balance exercises, or? They
say the best form of exercise for balance training is Tai Chi.
Okay.
I've never done it myself, but I've heard that it's very helpful for that.
Right.
And patients have always, or have said that they enjoy it.
Great. What are some of the newest treatments available? Is there any new treatments or research on the horizon that's in the whole field?
The newest medicine on the market, which now isn't all that new, it's been out for at least 4 years, is denosumab, which is a twice-yearly injection.
Okay.
And it's newer in that it acts through a different pathway, which I won't get into, but a different pathway to prevent bone loss from the more traditional medicines that we've been using for many years, which are called the bisphosphonates. Fosamax, Actonel are all in that class. There are some studies going on for another class of medicine, so a whole other group of medicines that act at the level of sclerostin. I won't go into what sclerostin does in the body, but I just want to point out that it's another totally other type of medication.
Okay.
And those medicines are currently in phase 2 and phase 3 trials.
And all about preventing further bone loss, or any research about actually growing new bone?
Yeah, these are again, maintenance medicines. They're to prevent further bone loss. The medication on the market that actually causes bone growth is called teriparatide.
Okay.
It's parathyroid hormone given in very small doses through a self-injection once a day. So patients actually have to give themselves an injection once a day, and we only use the treatment for about 2 years. And the reason for that is that when it was studied in rats, it caused bone cancers.
Oh, okay.
So that hasn't been seen in humans, but to prevent the risk, we only use it for 2 years. It is an excellent medication reserved for people with severe disease, multiple fractures, where we really need to resort to that type of medicine.
Okay. So not something that any individual would, if they've just been diagnosed with, it's really, once the disease has really progressed, that they'd be a candidate for that. So.
Usually, and it's a matter of need. Most patients don't require that medication, fortunately. But those that do, we use it often.
Any medications that put you more at risk? I've heard that proton inhibitors, stomach medications can sometimes put people more at risk. Is that true, and are there others that put you at risk for osteoporosis?
Yes, so you're absolutely right. The proton pump inhibitors, which are medicines that are used to treat heartburn, peptic ulcer disease, do increase your risk for osteoporosis slightly. So when we talked about risk factors for osteoporosis, in that list of risk factors, we included medications, and one would be proton pump inhibitors. The biggest culprit is prednisone or steroids. So anyone on chronic prednisone or taking steroids, doesn't have to be continuously, but say more months than not, or say more than 6 months out of the course of a year, is at extreme risk for osteoporosis. Other medications that we need
steroids can actually accelerate the bone loss, or?
Yes, they do.
Really? Okay.
Absolutely, and they're the most damaging.
Right.
In fact, so much so that our patients in rheumatology that we use steroids for, which we often need to use, are put on medicines, osteoporosis medicines, to prevent the bone loss from the steroid use.
Interesting.
As a prophylactic measure. And then some other medications that can cause bone loss are seizure medications and thyroid medications. So it's not that you should stop taking those medicines. It's very important that you stay on them. But a conversation with your doctor about perhaps getting an earlier bone density screening test would be appropriate.
Important to know, because those medications are being used for clearly other reasons, and we need to be careful with that.
It's not a reason to not take them, but rather, to look into screening for osteoporosis, or perhaps going on medication to prevent bone loss.
And typically, if you see a new patient, what's the kind of information you're looking for? And I like to ask patients or doctors sometimes, if I'm going to be an intelligent patient, what should I be thinking about, making sure my doctor knows? And as you're looking at somebody as a potential risk for osteoporosis, what would you look for?
So it's very important that you bring the most recent bone density report that you have, if one has been done.
Right.
Most of the patients that I see as a rheumatologist are coming to me because they've either failed their therapy for osteoporosis, or they have fairly severe disease that they require a specialist. Usually primary care doctors are doing the mainstay of screening for the disease. So I need the most recent bone density, most recent blood work, whatever happens to be available, an accurate list of medications. It's surprising how many people say, well, I take this purple pill in the
Right,
morning. and
exactly.
the
I have no idea
yellow-"
what it is, but somebody told me to take it once.
So an accurate list
Right.
of medicines so that we know exactly what is being prescribed
Right.
are probably the main things that we need. And then any further testing is done, after that office visit.
Great. I know we're out of time, unfortunately, but you are now seeing patients as part of Meeting House Lane and available to take appointments and referrals for osteoporosis in addition to rheumatology. So certainly very, very lucky to have you here, Dr. Roppelt, and I'm very happy you joined our medical staff, and thank you for being with us today.
Well, thank you, Bob. It's been a pleasure.
And I'd like to thank all of you for watching us today, and also if you'd like additional information, would like to make an appointment for a consultation with Dr. Heidi Roppelt. She does see patients at the offices of Meeting House Lane Medical Practice at the Hampton Atrium and Hampton Bays. Her office number is 631-594-3910, and I know that number will be displayed as well. Again, I'd like to thank everyone for watching. I'd like to thank our friends at CTV for producing and airing this show in our communities in Southampton, and our friends at LTV for airing the show in East Hampton. If any of you have questions or concerns, would like more information about osteoporosis or how to get in touch with Dr. Roppelt, please call my office at 631-726-8555. We're very happy to help you out. If you have an idea for future programming, please let us know. We'd like to hear from you. Hope you all have a very happy and healthy holiday season, and good health, everyone.